So anesthesia for microlaryngeal surgeries. First, always any surgery, my habit is to identify the challenges that you face in these sort of cases. Okay, any clinical scenario, I always prefer to analyze the challenges that you face before you go into the explanation, whether it is practical viva scenario or whether it is a theory. You can first describe the challenges, then go for pre-op evaluation, intra-op management, post-op complications. Exactly. Okay. So the challenges here are, as you rightly said, is a shared airway. What is the difference in the shared airway between a tonsillectomy and a polypectomy from the removal of vocal cord? When you do a tonsillectomy also, you are sharing the airway. When you do a palate surgery also, you are sharing the airway. Is there any
Yes, sir.
difference between sharing the airway in a tonsillectomy or a palatoplasty compared to a vocal cord procedure or a subvocal cord lesion, subglottic narrowing? They want to dilate or reconstruct. What is the
Intrathecal
difference
tube will
The
be
between the
working
two?
space
changed.
is low, sir.
The patient need
Pardon?
a endless tube for the vocal cord surgeries, and then for tonsils, so it can use normal tubes.
Because tonsillectomy, palatoplasty, they are all considered purely upper airway surgeries. Okay, so you can have a definitive control over the airway by intubating those patients. The surgeon won't mind you intubating those patients. On the contrary, any procedure on the vocal cord or below the vocal cord, sometimes the surgeon may request you to avoid intubation. So you don't have a control over the airway in that way. Even though you are sharing it with the surgeon, you don't have a proper control, and anytime patient can hypoventilate, desaturate, or get obstructed. So all that risk is always there in a microlaryngeal surgery. Whereas in the upper airway surgery like tonsillectomy or palatoplasty, that risk is not there. Even though you are sharing, you have a control over the airway by you are able to intubate the patient. And for microlaryngeal surgery, the other important thing, you must maintain adequate depth of anesthesia to suppress the airway reflexes. And the protection of lower airway from aspiration and blood and debris is very, very important. And that is why even if you use a microlaryngeal tube, they are all cuffed tubes so that any blood or particles trickling from the site of surgery does not migrate down, especially when you use a jet ventilation or a high flow ventilation. There is a possibility you can sweep all the debris or blood clots into the lower airway. So that also has to be taken care of. And maintain ventilation without obstruction to the surgeon's view and access to the lesion. This is another challenge that you have to face in this case. So these are the 4 important challenges that you have to remember. Now coming to the preoperative evaluation of these patients, patients with microlaryngeal, they present with either hoarseness of voice or change of voice or difficulty in breathing, and inspiratory or expiratory stridor may be present. Okay, so these are all the various clinical presentations they come with, and they may present with dysphagia also. It may not be totally connected to the voice, but their main complaint may be difficulty in swallowing. So that may be the important pre-op complaint. And they might have undergone some procedure either for diagnostic or therapeutic purpose earlier, and maybe of all ages. You can get a congenital polyp present in the childhood, or it may be in the adult age, or it may be in the geriatric age. So you get patients of all ages, and they may have associated congenital or acquired conditions other than the airway diseases. Especially if they are adults, they may have smoking related complications. They may have hypertension, they may have ischemic heart disease, elderly patients, and diabetes mellitus and thyroid diseases also may be present. And sometimes congenital cardiac anomalies in the pediatric age group is also quite common. So one important assessment you have to make in the preoperative phase, you must ask the patient in what position he is able to sleep well. Is he getting obstructed by sleeping supine, or Does he avoid that by sleeping on the lateral only or in the prone position? So the best breathing position and breathing pattern during sleeping, that will give you a clue about the severity of the disease. If the patient says, I am not able to lie supine facing the ceiling, that is a very, very tricky situation, because once you put him in the supine position and try to induce him to plan to give a GA, you may land up in a situation where you cannot mask ventilate the patient also, because the lesion will totally obstruct. So in such situation, you have to plan for a induction in the lateral position, which is comfortable and which is he is used to. So this question is very, very important in all the microlaryngeal lesions. And then history of any previous endoscopic procedures and their outcome. That history is also very important. Sometimes, they'll end up with a complication and the previous surgeon would have abandoned the procedure and recovered the patient. And then the patient doesn't want to continue treatment with them. They come to a new surgeon and you may be seeing them after a earlier failed attempt. So this history is very important so that you can plan your anesthesia to avoid again another problem and cancellation of the surgery. And important to know the location of the lesion, whether it is inside the airway or near the airway, since there is possibility of life-threatening airway obstruction during induction. This is a very, very important thing to avoid any complication happening during induction. And during manipulation of the airway lesions, bleeding or edema can occur, and that may also cause airway occlusion. And oropharyngeal examination should be evaluated carefully to assess whether there are difficulties during intubation of the trachea if you plan to do an intubation. And just like assessing the difficult airway, you must do the neck movement mobility as well as the difficulties with airway management. And preoperative investigations, usually we do a CT scan, MRI, X-ray of the head and neck, which will assess the or give you a clue about the potential difficulties. And patient may present with a endotracheal tube intubation or a tracheostomy, a large lesion which has already started obstructing the airway. Sometimes they do a tracheostomy and patients may come to you with a tracheostomy or previous intensive care admission, especially the newborn with a congenital pathologies in the vocal region or laryngeal region, they might have been treated in the ICU. And the discussion with the surgeon is very, very important for any potential airway difficulties. And then to know the plan of surgery also, whether he wants to have a tube or not, how long the procedure will take, whether you want to paralyze or whether you can rely on intermittent apnea technique. All these things will be better discussed with the surgeon so that you can have a plan according to the lesion. Then pre-op preparation of this patient, they should be asked to stop smoking, can use bronchodilators. The patient is with tracheostomy, you can give steam inhalation and nebulization through that and remove all the secretion by liquid suction before you take up the patient. And the indications, common lesions which are done with microlaryngeal thing are benign growth, nodules, polyps, cysts, etc. from the vocal cord, granulomas, or vocal cord dysfunction. They do what is called plasty of the vocal cords, and then obstructed tumor removal, recurrent respiratory papillomatosis or foreign body, or all these things which are managed by like microlaryngeal surgery. Pre-medication, sedative pre-medications are avoided, especially if the airway likely to obstruct the passage and there is a chance of respiratory difficulty. Anticholinergics like your glycopyrrolate can be used to decrease secretions and also avoid bradycardia. Anesthetic technique planned for microsurgery, there are three things as I said. First thing, you must decide whether you are going to do it under topical spray with lidocaine or whether you are going to go for conventional general anesthesia. And patients who are cooperative, small lesions which can be removed easily, can all be managed under topical itself. But anxious patient, uncooperative patients, children, in all these cases, you have to definitely think of giving GA. The second thing is whether you are going to intubate or have a tubeless anesthesia. And the third thing is whether you are going to preserve the spontaneous respiration by not giving any relaxant, just depend on PIVA or inhalation induction agents, and or whether you are going to paralyze the patient with non-depolarizing muscle relaxants and controlled ventilation. In the case of controlled ventilation, whether it is going to be through a microlaryngeal tube or through the standard or high frequency jet ventilation technique is the next thing that you have to plan. So intubation technique requires a very specific small diameter microlaryngeal endotracheal tubes, and that will provide adequate space for the surgeon to tackle lesions like vocal cord polyp or granuloma. And sometimes for many of you may not have seen, especially the juniors would not have seen a microlaryngeal tube. So it is a small internal and external diameter. Unlike your regular conventional oral PVC tubes that you use in your day-to-day practice, they have a quite a sizable difference between the internal diameter and the external diameter. Whereas in the microlaryngeal tube, both the internal and external diameters are smaller compared to the regular tube of the same size. For example, if you take a 5.5 mm internal diameter tube, which you use for a pediatric case, the outer diameter of the regular pediatric tube will be larger compared to the microlaryngeal tube, which will have a smaller diameter outside also. And these tubes will have a little longer length so that you can use them orally and nasally. And the usual sizes that you use will be between 4 to 6 millimeter, and they will be of 30 centimeter length. And they have low pressure, high volume cuff. And when you intubate, they usually lie between the arytenoid and leaves at least the anterior commissure will be free. And here you can see the difference between a pediatric tube, which is say 5 size tube, and the outer diameter will be much larger than this. This is a microlaryngeal tube, and they have a low pressure, high volume cuff to prevent any material going down the lower respiratory tract. And now these are the two tubes I am showing, which are all microlaryngeal tubes. Compared to this tube, these two tubes, can you see what are all the differences in this? By just looking at the tube, look at all the angles of the tube as well as the pilot balloon, everything. And can you observe some very blatant or very visible differences between these two tubes?
This looks like a metallic reinforcement tube, sir. The right one.
Like a, but this is not
The
a metallic reinforced tube.
And the cuff also looks high volume cuff, sir.
Cuff also looks. Do you find any difference in the bevel?
Yes, sir.
Do you find any difference in the starting point of the pilot balloon?
It started earlier, sir.
See, this is a regular pediatric tube. The pilot balloon's connection tube starts almost very close to the cuff in the pharynx. Whereas if you see here, it starts here. It's almost outside, but near about the distal connection. And the bevel also is facing posterior. Okay, so this is the proximal pilot line, very close to the connector, whereas this is a distal pilot line. The after inflation pilot line is very distal here, whereas it is quite proximal here. And the second is the cuff will be facing posterior. So that is the main difference in the classical microlaryngeal tube. And can you identify this tube? It was the very early version of microlaryngeal tube without a cuff. This was the original tube used during the 80s and 70s. During our PG days, we used to use only this tube. Can anyone tell me the name of this tube? Where it looks like a ink filler. It is small uh, brachial end and a larger machine end with an adapter. Try to find out and tell me before the end of the class. Okay. Advantages of microlaryngeal tube are there is no special method for introduction. You can use the routine method, and it because of the cuff, large cuff, it protects the lower airway. And through this tube, you can paralyze and control the ventilation, and you have a control over the airway. And because of the cuff, it will have minimal pollution by the volatile agents, and we can attach a ETCO2 monitor and monitor the ETCO2. So these are all the advantages of using a microlaryngeal tube. The disadvantages of microlaryngeal are surgical access and visibility of lesion may be limited. You require high inflation pressure because of the smaller diameter, and if your patient is allowed to breathe spontaneously, you will have to, it's just like a negative pressure pulmonary edema. He has to breathe through a high resistance, so longer duration of spontaneous ventilation with a microlaryngeal tube can result in a NEEP, negative pressure pulmonary edema. And difficulty in suctioning. If there is secretions or blood clots, it will be difficult to suction through that. And these tubes can easily get occluded because again of the narrow diameter, or it can get clipped, and tube related damage to vocal cords can sometimes happen. And these tubes, unless you specifically choose a laser resistant, they can catch fire if the surgeon is going to use a laser. Okay? So these are the disadvantages. And so if the surgeon says, I don't want the tube there because the lesion is in the lower part of the larynx and I want a clear access to remove that. So he says you better do a non-intubation technique. Then the options are, it can be intermittent apnea, you can do insufflation technique, or you can allow spontaneous ventilation, and you can use jet ventilation. These are the four options. Now we'll see how to do that. In case of non-intubation technique, it cannot be done under, it can be done of course under topical with the patient breathing spontaneously, but if the patient is not cooperative and if it is going to be a prolonged procedure where patient may not be comfortable, especially if the surgeon is going to use a rigid laryngoscope, which I will be showing shortly, then the patient will have to be put in an extreme extension of the neck and all that. That may not be tolerated for a longer duration. So in all such situations, you have to do it under GA. So induction is usually done for, as you do in any other case. But only thing is, you have to make sure that the airway should not be getting occluded or obstructed during your induction. So that is the very important thing that you have to assess. And if there is no fear of obstruction of the airway during induction, then you can pre-oxygenate the patient adequately as you do for any other case. Then give propofol 2 to 3 milligram, and you can give a muscle relaxant like IV succinylcholine 2 milligram per kg. And then you continue to ventilate the patient with inhalation agent like oxygen and sevoflurane. And then in case you plan to do a tracheal intubation, you do it with a microlaryngeal tube. Otherwise, what you have to do is, once the patient is paralyzed, especially if you are using succinylcholine, the duration of action of succinylcholine will be only for about 3 to 4 minutes or 5 minutes at the maximum. So during that time, you hand over the patient after adequate oxygenation, and surgeon will quickly introduce the rigid laryngoscope, and you can ventilate the patient through a Sanders technique by injecting, delivering oxygen and even a mixture of your volatile anesthetic through the side arm, and then ventilate the patient with a high flow jet like Sanders, Manijet, and other things. And until the patient regains spontaneous ventilation, you can ventilate through that. And once the patient regains spontaneous ventilation, in the earlier days, we used to repeat a second dose of Scolia. And the common question the examiners will ask you is, you are oxygenating the patient by giving oxygen and the volatile. But what about the carbon dioxide elimination? Will he have a normal ATCO2 or will the CO2 build up?
CO2 will build up, sir.
Build up. So what is the rate at which it will build up? That is a common question examiners will ask you. How many millimeters it will rise per minute of apnea? So it is roughly 3 millimeters per minute. Okay, EtCO2 or the carbon dioxide level in the blood will, because there is no active ventilation, CO2 will build up at the rate of 3 millimeters of CO2 per minute of apnea. So if the patient is apneic for about 5 minutes, you can expect the EtCO2, I mean the blood CO2 to go up to 15 millimeters. If you start with 40, it may go up to 50, 55. Okay, so that is the disadvantage of this prolonged apneic techniques. You cannot do it for a long time. So then anesthesia can be maintained with oxygen sevoflurane, and if you have intubated, you can paralyze the patient with a non-repulsive muscle relaxant like atractorium or tractorium. And again, through tube, you can do the regular controlled ventilation, assisting the ventilation through the tube, or again, you can do the standard jet ventilation or high frequency ventilation to ventilate the patient, and you can flush out the you can oxygenate the patient through that. And awake fiber optic intubation of the trachea, the topical anesthesia is the choice for any anticipated difficult airway cases. So after discussing with the surgeon, if you think there is going to be problem after inducing the patient to become unconscious and then giving relaxant, it is going to be problematic. Safest technique will be to do an awake fiber optic intubation as you do with other techniques. Monitors, the regular monitors plus airway pressure monitors is also very, very important. Apart from the regular standard monitors which are required, airway pressure monitor will tell you about, especially when you use a high flow or a jet ventilation, airway pressure will don't allow it to exceed more than 20 to 25 milliliters of mercury. And allowing spontaneous ventilation by inhalation route with sevoflurane and oxygen can be done in anticipated difficult intubation cases. Instead of IV induction, you take them just like you do inhalation induction for pediatric cases. Adult patients also can be induced with spontaneous inhalation agent. The advantages, there can be an excellent visualization of the surgical field and the ability to evaluate the vocal cord function because the patient is breathing. They can see if there is a paralysis or partial paralysis of the vocal cord. You can find out which one is affected, and sometimes repairs can be done also after topicalization and the patient is breathing. And the disadvantages of oxygen and ventilation can be more difficult to assess. The surgical field is not still. So they want to do any removal of a polyp or anything from the vocal cord. In a spontaneously breathing patient, it is more difficult. And there is always a risk of aspiration, and depth of anesthesia may not be consistent in these patients. The patient is likely to get lighter plane of anesthesia, which may lead to laryngospasm and all problems are there. Coming to the second insufflation technique, you done it with a small catheter in the nasopharynx placed above the laryngeal opening, and the oxygen and volatile anesthetic agent will be and or you can use a tracheal tube which is cut short and placed through the nasopharynx, just emerging beyond the soft palate. So you can take your regular EP tube and then insert it nasopharyngally and then just keep it above the vocal cord and through that you give a high flow rate of oxygen, nitrous oxide, unvolatile anesthetic agent. And all these things usually, if insufflation is there, you have to preserve the spontaneous ventilation because there is no pressure. You cannot have a controlled ventilation or you cannot oxygenate the patient. So naturally, you have to preserve the spontaneous ventilation and allow the patient to inhale the direct delivery of the gases and the very close to the laryngeal inlet. And it can also be done with an nasopharyngeal airway or side arm or channel of the laryngoscope. All these things are the methods of insufflation technique. And the disadvantage, there is no control over ventilation. There is a loss of protective airway reflexes, and there is a likelihood of airway soiling. And the gastric distension can happen because in order to maintain the depth of anesthesia, we give a high flow rate. So that may enter the relaxed cricopharyngeal sphincter, and gastric distension also can happen. And during exhalation, most of the gases will come out in the open and theatre pollution will happen. And it is not suitable for any soft floppy lesions where it will flutter like your doorway. And if you want to have a control over the ventilation, what are all the ventilation techniques for microlaryngeal surgery? Usually, we nowadays resort to total intravenous anesthesia using either propofol and remifentanil, or now they use dexmed also. And continuous infusion of propofol and remifentanil with or without superior laryngeal nerve block can be done. And maintaining spontaneous ventilation allows the surgeons uninterrupted and unobstructed surgical access for what is called the suspension microlaryngoscopy. And supplementation with mask ventilation, jet ventilation, endotracheal ventilation may be necessary during periods of hypoventilation or desaturation. So earlier they used to first intubate the patient in cases where it is a class 1 or class 2 airway, where you can remove and intubate the patient very easily. The technique they used to adopt it, give induction agent, follow it with a paralysis with a short-acting muscle relaxant, intubate the patient, and then take him to the adequate surgical depth of anesthesia, and then remove the tube and allow the surgeon to fix the laryngoscope, everything, and work out on that. These are all possible only if the lesion is small enough and we can finish the entire procedure within 15 to 20 minutes. In such situation, you can remove the tube, allow the surgeon to go ahead, and then supplement oxygen through the side arm of the rigid laryngoscope. And then if the patient desaturates or becomes lighter, you can again re-intubate and take the depth of anesthesia. But these are all quite cumbersome. But after the advent of this jet ventilation, most of the problems are solved. I'll show you how. And you can use high flow nasal oxygen, more than 15 liters via nasal cannula for upper airway surgery while maintaining again spontaneous ventilation. And complications of this ventilation, because you are sharing the airway and with or without the tube in position, patient can desaturate, patient can build up carbon dioxide, and if the laser is being used, you can get airway fire also. And Thrive, which is a newer method, transnasal humidified rapid insufflation ventilatory exchange. It's very useful in reduce the time of apnea window. So because the Thrive will definitely move the oxygen into the lungs, the patient of the desaturation time is quite prolonged in these cases. From the normal 2 to 3 minutes, it can be prolonged up to 10 to 15 minutes also by using this Thrive machine. And this has allowed up to 17 minutes of apneic time without signs of carbon dioxide toxicity. Because of the high flow that you are using, even the carbon dioxide gets washed out and does not accumulate like the earlier days. So this is the advantage of Thrive. And the rate of carbon dioxide accumulation, I asked you the question, but here the answer is 0.15 kilopascals. If you with Rye, whereas it is 0.45 kilopascals. So 1 kilopascal, all of you know, is 7.5 millimeters of mercury. So roughly less than half. So what I told you is 3 millimeter per minute is the accumulation. So 0.45 kilopascal is roughly equal to 3 millimeters per minute. In patients undergoing traditional apneic oxygenation and those with airway obstruction, this will be the hypercarbia that will happen. And you can use continuous positive airway pressure, CPAP of 7 centimeters, which will also help in splitting the upper airway and reduce the shunting or desaturation. And continuous insufflation facilitates carbon dioxide clearance because in the thrive you supply 60 to 70 liters of oxygen at a fast rate, so that clears the carbon dioxide and it causes the flushing of the dead space also. So patient will be filled with more of oxygen and you can maintain anesthesia with TIVA. So by using TRI and TIVA, nowadays most of the cases can be easily managed. And if the intraoperative laser is being used, indicated for treating stenosis, recurrent respiratory papillomatosis, malignant and benign laryngeal tumors, polypoid degeneration, that is Rinke edema, the commonly used lasers are carbon dioxide and KTP lasers. This KTP, as I told you, is potassium titanyl phosphate laser. You use a special what is called laser flex cupped endotracheal tube, which is laser resistant, and it has usually two cuffs. So in the exam, the specimens, they may show you this sort of tubes and ask you to identify. So if you find two cuffs, it is one of the laser resistant tube. And the second cuff provides a backup seal in the event of damage to the proximal cuff. And the cuff position should be checked after intubation and patient positioning because there are no markings like your regular ET tube which you are using, where you have graduations up to 26 centimeters in your regular tube at every interval. This markings will not be there. So there is no depth marking in laser tube. That is another method of means of identifying the laser tube if they give it to you in the exam to identify. And this is the picture you can see. There are two cuffs, proximal cuff and distal cuff, and there are two pilot the inflation exits. And you can see there are no markings at all, like what you see in the graduations, the normal tubing, that will not be there. And so, and it is filled with saline, tinted with methylene blue, unlike your regular endotracheal tube, which you inflate with the air. It is always filled with the saline mixed with a little bit of methylene blue. And any puncture with the laser, immediately that fluid will come out and the yellow, blue thing will be seen there. So surgeon can identify that he has punctured the endotracheal tube. And supposing that sort of complication has happened, surgeon should alert the anesthesiologist in advance. And the inspired oxygen concentration should be reduced to 30%. So one of the important things that you have to do in immediate treatment of laser fire is reduce the oxygen concentration because high concentration will help in further enhancing the fire, and the nitrous oxide should be discontinued. And complications arising from laser can be in the form of gas embolism, laser plume creation, retinal injury. So all surgeons, patient, and other paramedics working in the theater should wear goggles, and the operating room fire can happen and damage to vascular structures can happen. And the next option is high frequency jet ventilation via catheter placed in the cricothyroid membrane. It is below from outside, useful in oxygenating patterns undergoing microlaryngoscopic and laser surgery. And manual jet ventilation with automated high frequency jet ventilation. And this is the high pressure system ventilation technique. And the commonly used type of jet ventilator is a Sanders type. that may be kept in the exam as a part of the equipment, and it gives a fixed pressure of 4 atmospheric pressures. And what will be the volume delivered? What is the principle behind the Sanders jet ventilator or Sanders type of injector? What physical principle it works on?
Venturi's principle.
Venturi principle, yes, that is one of the examples of Venturi principle. What are all the other examples of Venturi principle? Where else Venturi principle is used apart from this? Sanders jet
Nebulizer.
ventilator?
Yes, sir.
Nebulizers, very good. And even suction apparatus.
Yes, sir.
Okay, so these are all the common other uses of Venturi principle. So Sanders work. So if you deliver 10 liters of oxygen, it will entrain air from the atmosphere when it is delivered through a small nozzle because of the Venturi principle, and the volume delivered will be more, but the oxygen concentration will become less. Okay, that is the important thing about Sanders jet ventilator. And to prevent this 4 atmospheric pressure is quite a high pressure, so the chances of barotrauma are high. So to control that only, they made another part of it, what is called the manual jet, where you can adjust the pressure between 0 to 4 atmospheres by pressing that. I will show you the picture of all those things. So jet ventilation can be delivered via supra, trans or transglottic and transtracheal routes, and high pressure, high frequency jet ventilation does not hide the posterior glottis and reduces the risk of airway fire. And this is what is called the manual jet. Okay, so this is the high pressure connection to that, and you have a dial to show what exactly is the pressure that is being done. And this long handle you see is what is called the toggle handle. By pressing it fully, you will deliver at a very high pressure. By pressing this partially, this is the tube which delivers the oxygen and the agent that you want to give. So by adjusting the pressure on this handle, you can decide what pressure you want to deliver. Whereas the earlier Sanders ventilator used to deliver exactly at the 4th atmospheric pressure all the time. So that is a small modification in what is called manual jet compared to the Sanders original jet ventilation. And this is the jet that is available in the modern machines. You can see this blue color is the jet delivery with a high pressure inflow. And this proximal red one is used to measure both the EtCO2 as well as the airway pressure. So such sort of adaptations are available in the modern machines. Instead of having a separate connection, the modern machines are able to deliver these things. And it may be used to provide, when you have the jet ventilation, you can use it to provide post-op oxygenation also during recovery. The adverse effects are related to the puncture through the kyphoscolate membrane, mechanical problems, low saturation, carbon dioxide retention, and also barotrauma. Pneumoperitoneum, pneumomediastinum, subcutaneous emphysema, and pneumothorax, which are all because of the high pressure, that barotrauma problems are also there. And this is what I showed you is the green laser being used in the as an office procedure. You can see everybody is wearing the goggle, and patient has been anesthetized with a topical xylocaine, and the endoscope has been introduced through the nostril, and the side arm beam is also going there, and this will be the picture. So the laser is going in, cutting the lesion. And this is the pre-op picture, intra-procedure picture, and this is the post-op. You can see a smooth vocal cord going to that. So laryngeal laser surgery under local anesthesia. This is how it is being done as an office-based procedure. And this is the classical picture where patient has been intubated. You can see the endotracheal tube with a breathing circuit, and this is the rigid laryngoscope which has been introduced, and surgeon is using the microscope to, and this is the forceps he uses to catch hold of the lesion. He has introduced it through the rigid laryngoscope, and you can see how much of extension is being given in the head. So long procedures cannot be done under topical. You definitely require DA for a successful. And this is another picture of how this close view, this is side view, how the things are introduced into that, and this is the frontal view where you can see the lesion, or the red thing is the lesion that is being seen through the vocal cords, and unmagnified. This nowadays we have a camera attached to this, and the surgeon can see it in the monitor instead of seeing it through the eyepiece. And that facility is also there. And this is the picture of a Sanders jet ventilator. You can see this is the high pressure oxygen delivery tube, and this is the control mechanism. And another high pressure tube goes into a small nozzle being delivered at the proximal end of the, or the surgeon's end of the rigid laryngoscope. And once the oxygen gets delivered here, it will entrain atmospheric air from the outside and deliver a higher volume but reduced oxygen concentration. So this is how the jet ventilator works. And this is the picture of a rigid laryngoscope before it is introduced into the patient. And these are the two side arms, one for delivering the oxygen or the volatile anesthetic agent mixture, and another for using the airway pressure also can be measured through this. And these are some of the pictures of how the jet laryngoscope is being used. So low flow or high flow jets will be connected here, and the humidification is also done. And airway pressure and gas monitoring can be done through that. And this will go into the patient's oropharynx. And this again is a picture how they work with that. And this is how the mounting stand just compression is avoided by another support of this base of the fixing system. And with that tube, this will be the picture. An anterior vocal cord polyp, and this is the posterior portion. This is the anterior commissure. So anterior commissure will be free when you do a microlaryngeal intubation. Okay, so this can be easily removed. Whereas if the lesion is here, it will be very close to the tube. So in that situation, surgeon will ask for a tubeless anesthesia. And this is another picture of a vocal cord polyp, which is like a small bubble. So that also the picture visualized before excision. Okay. So these are all the things that you have to know about microlaryngeal surgery. So those pictures mainly for those of you who have not had a chance to work in an ENT theater where they do microlaryngeal procedures. So I hope these pictures give you an idea about how to manage these cases. Okay. Right.